So good evening, everybody. On behalf of Department of Pediatric Ophthalmology and Neuro-ophthalmology, Shroff Charity Eye Hospital, I welcome each of you to another episode of virtual learning. Now we know that attending webinars has just become the new normal of our daily academic schedule. So today let us participate in this session on neuro-ophthalmology diagnostics and learn from the national and international experts of the field. At the outset, I would like to thank all our esteemed speakers and panelists for consenting to be a part of this program. I would also thank our sponsors, Team Neomedics, for supporting us. Nonetheless, I would like to thank our HOD, Dr. Suma Ganesh, who has been a backbone of all the successful webinars so far and allowing us to conduct a neuro-ophthalmology session. So with this, I would like to introduce our speakers and the panelists of the day. So today we have with us Dr. Rohit Saxena. All of us know he needs no introduction. Currently, he's the professor of ophthalmology at RP Center, a wholesale Amesonian. He's a pioneer in the field of neuro-ophthalmology and is presently secretary to the INOS. He has been awarded as the Esteemed Research Teacher Award multiple times. And let's learn from his important tips and pearls in today's session. We also have with us Dr. Virender Sachdeva, who is the head pediatric ophthalmology and neuro-ophthalmology at the GMRV campus of LV Prasad Eye Institute, Visakhapatnam. He has pursued his pediatric ophthalmology fellowship at LVPI Hyderabad and also a clinical research fellowship in neuro-ophthalmology, Emory University. The areas of interest of his are complex strabismus, reoperations, imaging in strabismus, amblyopia, and neuro-ophthalmology. And we have with us Dr. Sonali Gupta, who currently is working as a consultant at ESIC Model Hospital, Noida. She has done a long-term fellowship in pediatric ophthalmology and neuro-ophthalmology from the Birmingham and Midland Eye Center in UK. And she's currently affiliated to all the 3 Royal Colleges of UK. She'll be talking to us on visual fields. I would also like to invite now Dr. Sonali to introduce our guest speaker of the day.
So we have an international speaker with us who is our guest speaker for today. She is an associate professor of ophthalmology at the University of Wisconsin School of Public Health, currently practicing at the UW hospitals and clinics. She has over 20 years of diverse experience in both ophthalmology and neurology. So she is the right speaker to talk to us through both neurology and ophthalmology today. Her research interests are an association between the eye and general well-being using pupil reactivity. She will take us to the MRI of the visual pathways. Coming to the next speaker with us today is Dr. Digvijay Singh, who is a director of the Noble Eye Care in Gurugram and head of ophthalmology at Narayana Hospital, Gurgaon. He is currently the president of Young Ophthalmology Society of India and a treasurer of Indian Neuro-Ophthalmology Society. He will tell us about the OCT pearls and pitfalls. And then last speaker with us today is Dr. Sovita Rath, who is currently working as a consultant at Dr. Shroff's Charity Eye Institute. She has done a long-term fellowship in pediatric ophthalmology and neuro-ophthalmology from the prestigious LV Prasad Eye Institute and is actively involved in the various teaching and training programs at Shroff Charity. She will talk us through the valuable VP today. Thank you.
Thank you, Dr. Sonali. So the first presentation will be regarding fields. This will be presented by Dr. Sonali. Dr. Sonali, you can share your screen now.
So we'll talk through the visual fields today, which are important to diagnose any neuro-ophthalmological condition. So just to know what the normal visual fields are. So as we know, they extend superiorly up to 60 degree as well as nasally. Inferior fields are 70 degree and temporal is the largest with 100 degree. There's a blind spot, which is a physiological scotoma represented on the field chart, which represents the site where the optic nerve leaves the eye. So why do we need to test these visual fields when we can already measure a visual acuity of a patient? So this is an important marker of visual function, which goes hand in hand with the visual acuity, because at times it is possible to have some field defect even with the normal vision. So a patient coming to us with some complaints saying that I cannot see properly, but the vision being 6/6, we just can't attribute to it to be just normal until we check the fields and confirm it. At times, we can have a normal eye examination, but there's a presence of field defect, which prompts us to look behind the eye into the brain to determine the cause of the same. Sometimes field defects can also present as diplopia, which is due to a phenomenon called as Henny field slide. So there are different type of tests which we can do to see the various visual field defects. The first and the most easy, which can be done at bedside without the use of any sophisticated equipment, is the confrontation visual fields. It requires good clinical skills on part of the testing doctor. One can reach a diagnosis without any sophisticated machinery. It is quick to perform and is easy for the patient. It can detect up to a large peripheral degree as well. So it can be done with a moving finger or with a red or a white hat pin, which have its specific uses. The red pin is usually used to map the macula as well as the blind spot, while the white pin is used to map the periphery. Then coming next is the Goldman kinetic perimetry, in which a moving target is brought out from the periphery, and it requires a trained perimetrist to perform this test. Its advantage is that it can be done even with a very low level of visual acuity, worse than 660 as even, and it can test a large degree of periphery. But the disadvantage is that there are no standards or normative values, and it is highly dependent on the skill of the person performing them. The most commonly used type of field test these days, and which is widely available, is the static automated perimetry, a prototype of which is the Humphreys visual field, as we are all familiar with it. So it has standardized test protocols, age-related normative population values, less operator dependency, and their reliability index established. That is, we can look at the chart and see whether we can rely on the findings we have got based on the fixation losses and the degree of false positive and negative. So the first step to interpret any visual field printout is to place them correctly. So we should place the visual field of the right eye on the right side of the examining person who is interpreting the field, and the left eye of the patient's field have to be on the left side. Next, we have to see that where the blind spots are, just to be sure that we have kept the right eye field and the left eye at the correct place. Then there are few steps through which we need to go through a field chart for the interpretation. So the first step, which we look at a field and what we see is the test reliable based on the indices we have just seen in the previous printout? Then is it a normal field, or is there any area of decreased field? Is it abnormal? Is one eye affected or both eyes are affected? Does the defect respect the vertical meridia? Is it heteronymous or is it homonymous? Heteronymous would mean one eye has a field defect on the right side and the other on a left side, while homonymous would mean both have it on either the right or the left. So either one eye temporal, one eye nasal, we'll come further to it. And whether the defect is complete or incomplete and congruent, that is, the defect shape and size should be equal in both eyes, or is it different? So this is the visual pathway through which all the impulses from the eye travel to the brain. So looking at this diagram, we can see that the lesions depend on where the pathology is. The part of the visual pathway where the pathology is determines the type of field defect we have. So using the points we have just seen, we can reach a diagnosis as to where the lesion is situated. So the common parameters would be, is the test reliable? And here we can see they are abnormal. So next comes whether one eye is affected or both eyes. So as we can see that the topmost fields are the one where only a single eye is affected. And here the lesion lies in the optic nerve. So affection of one eye always signifies that the lesion is anterior to the chiasma. So it can be at the optic nerve or it can be at the retinal level, but never behind it. Then if it is affecting both the eyes, then the lesion could be anywhere behind the chiasma or further, or it can even be both the optic nerve. Then does the defect respect the vertical meridia? This usually happens in lesions which affect the chiasma and behind. Is the defect heteronymous or homonymous? So heteronymous defect usually happens when the chiasma is affected, causing a bitemporal hemianopia. So the right side of one eye and the left side of the other eye is affected. The next is whether it is complete or incomplete. So incomplete lesions usually help us to localize the pathology more. So coming to a few examples, So this is the visual field defect which we have. This is a printout of a right eye and left eye of a patient. So working through it based on what we have, the points we have discussed till now. So as we can see in this, only one eye is affected, which is the right eye. The left eye fields are normal. So based on our interpretation, the affection of one eye usually means it is anterior to the chiasma, it is in the optic nerve. Let's see what the further we can see. Does it respect the vertical meridia? As we can see, it is all around the center. There's no respect for the vertical meridia. So it further confirms that the lesion would be in the optic nerve, because chiasma and behind should always respect the vertical midline. These 2 points don't figure in because they are always applicable when it respects the vertical meridia. So we can see that there is a central scotoma in the right eye in these fields. Then coming to a second example, here again it is affecting only the right eye. It does not respect the vertical meridia, again signifying it's an optic nerve lesion. And we can see there is a centrocecal scotoma here, means it is involving the center as well as the blind spot, causing a centrocecal scotoma. So the differential of these kind of central, paracentral or centrocecal scotomas are usually optic nerve pathologies like optic neuritis, Leber's hereditary optic neuropathy, or if these findings are present bilaterally, then it means both the optic nerves can be affected, like in toxic nutritional optic neuropathies. So coming to the next example, here we can see that the field defect is present in both eyes, and it again does not represent the vertical meridia. So here, since it does not respect the vertical meridia, even though it affects both eyes, it is still an optic nerve lesion which is affecting both the optic nerves. So we can see that there is an enlargement of the blind spot here, which is a classical finding in papilledema. And this is another field defect where we can see only one eye is. So it affects the one eye, it is respecting the horizontal meridia instead of the vertical, showing that it's an optic nerve pathology. And here it's a vascular cause causing a left AION. So in such cases, we have to differentiate whether it's an optic nerve pathology or a retinal pathology by further examining the fundus. Because the examples we saw, although we discussed as an optic nerve pathology, but they can always mimic a macular disease, can have a central scotoma. An altitudinal field defect can also be in a vascular occlusion of the retina, and an enlarged blind spot can also be seen in syndromes like an acute idiopathic blind spot enlargement, all of which will have some abnormality on the fundus. So only a field defect cannot tell us the pathology. There are some special cases which do not follow the rules we have discussed. Like in this printout, we can see that both the eyes are affected. The defect respects the vertical midline only in one eye, that is only in the right one. The left one has a complete central scotoma, complete scotoma. Here, this case with complete field loss in one eye and a temporal field affected in the other eye is a special case of junctional scotoma, which happens when there's compression at the junction of optic nerve with the chiasma, because the nasal fibers from the contralateral eye just course into the other optic nerve, forming a von Willebrand knee. So the damage to these fibers along with the optic nerve causes a complete field defect in one eye and a temporal field defect in the other. So this is important because whenever we have a patient with an unexplained unilateral visual impairment, especially of the central field, then we must test the visual field of the opposite eye, just so that we don't miss the superiotemporal scotoma, which can help us to localize the lesion to the junction of the optic nerve and chiasma. So coming to a few more examples, here we can see that applying our principles, this affect both the eyes. So it can either be a pathology in both optic nerves or the chiasma or beyond. Then it is respecting the vertical midline. So now we know that vertical midline respecting, so it is definitely behind the optic nerve, that is the chiasma and beyond. It is either, whether it is homonymous or heteronymous, here we can see it's a bitemporal hemianopia, which is an heteronymous defect, signifying that it is a pathology of the chiasma. Then we can see that it is complete, but it is denser superiorly compared to inferior. We know that the inferior fibers of the chiasma are affected more, so the pathology should lie below the chiasma, like a pituitary adenoma. Had it been the other way around, that is been inferiorly more dense, then we could have thought of craniopharyngioma, which compresses from the top of the chiasma. Coming to another example here again, both the eyes are affected. It does respect the vertical meridia, so it is on the chiasma or beyond. But here we can see it's homonymous, that is, it affects the left side of both the eyes. So that's the temporal field of one eye and nasal of other eye. So it's a retrochiasmal defect. Since it's complete, so the pathology can lie anywhere from the optic tract, lateral geniculate body, optic radiation to the occipital cortex. Had it been an incomplete homonymous contralateral hemianopia, then we could have localized the lesion further to one of these locations. So coming to the lateral geniculate body lesions, they again have a contralateral homonymous hemianopia like the one seen in the previous slide, but usually they are incomplete based on the blood supply. They can have two patterns of field defect because they have a dual blood supply supplied by the lateral choroidal as well as the anterior choroidal artery. So the figure here shows the supply zones of both these arteries. Depending on which one is affected, we can have the wedge-shaped or the sectoral defects. Then again, optic radiation defects, they would follow the basic principle of having a contralateral homonymous hemianopia, but when they are incomplete, we can further localize the lesion based on whether there is a superior quadrantonopia, which means the inferior fibers are affected and the lesion is in the temporal lobe, or whether it's an inferior quadrantonopia signifying the superior fibers being affected and lesion being in the parietal lobe. Occipital lobe lesions follow some specific rules. They are very congruous. It means they would be very similar in their extent and density in both the eyes. The cortex has a dual blood supply. So again, we can have different patterns. In case of an extensive lesion, we could have a complete homonymous contralateral hemianopia. But usually if there's an infarct of the posterior cerebral artery, which is a common lesion to find in the occipital cortex, then we do have a homonymous hemianopia, but sparing of the macular area, as we can see in the middle central diagram in the photograph here. Sometimes there's a lesion only at the tip of the occipital lobe, where the central fields are represented, and we have a small homonymous scotoma just in the center if there's not a collateral circulation there. So as we can see, based on these different patterns, we can know where our lesion is situated. So as we have worked out through the various lesions, we just need to remember that we need to follow a protocol whenever we see a field chart based on the questions we have learned, that is which eye is affected, whether it is affecting the vertical midline, whether it is homonymous, heteronymous, complete, incomplete, congruous, incongruous, and mathematically we can work our way to where the lesion is. These fields are really important because they need to be done first for the diagnosis, as we discussed for the various lesions. Secondly, they are important for monitoring because like in few conditions like pituitary adenoma, usually we have a field test done pre-operatively before removal of the tumor. Then after the surgery is done to decompress, we need to do follow-up fields to see whether there is any recovery happening to the visual pathways. So they have an important role in monitoring the resolution of any effect on the visual pathways. Thirdly, we also need them to determine the amount of functional disability a patient is having. So to determine his fitness for driving or to give some help with the reading in case of hemianopic patients, we need to do these field tests. But the most important thing to remember is that confrontation fields is a really simple way to do it without any sophisticated machinery. And all the residents and doctors in their daily practice should apply more and more to their basic neuro-ophthalmological evaluation before progressing on to the formal fields. So thank you. I think I'll conclude my.
Thank you, Dr. Sonali. I think that was an excellent presentation. And I think she's covered everything. I don't see any questions in chat related to the topic. So I guess we can move on. A few key points she actually mentioned were fabulous. First was, of course, that whenever you have a patient with presentation in one eye, the most important examination is the other eye field or other eye investigation. So when we're looking at visual functions, we're looking at visual acuity, color, contrast, visual fields, and stereo acuity. So these are the 5 visual functions we must always test and look for whenever we are working up a patient. And as she's pointed out beautifully, the visual fields are an ideal way of localizing the lesion. And even in today's day of high quality investigations. You can tailor your investigations to the site where you expect the lesion to be. And it is still equally important to be able to localize the lesion, have an idea where the lesion possibly is, and tailor these vast array of investigations that probably we'll be learning about, so that you get better and more complete information. And there is just a question, where is the junctional scotoma, which degree within 30-degree field or not? So Sonali, would you want to take that question?
Yeah, so the junctional scotoma in the other eye where there's a temporal defect, it's in the far periphery, usually in the beginning. So we need to do a full field, 60-2 or a 120-2 to locate it. Otherwise, we'll tend to miss the temporal defect in the other eye.
So absolutely. So for neuro-ophthalmology, many lesions begin in the far periphery. So while we are very accustomed to the 24 or the 30-2, sometimes it makes a lot more sense to do a 120-point screen or the full field. And that's why all initial tests were done on the Goldman, because they give you the entire field. And a lot of lesions present from far periphery before they advance into the central 30 or 24 degrees. So and again, that's where confrontation helps you, because you are doing the full field examination. So again, the importance of a full field examination. Dr. Virender, any comments?
Dr. Sonali, wonderful presentation. You beautifully covered everything, and Dr. Rohit already highlighted majority of things. The only other thing I would like to say is that we have to keep in mind that as our main goal is to localize the lesion, it works best when we are using the fields of two eyes together. Unlike glaucoma, where we are looking at the field of one eye at a time, we are here going to see the fields of the two eyes together. Like you showed, keep the field of the right eye on the right side, keep the field of the left eye on the left side as the patient sees, and then we take it exactly further, and then use the rule of 7 which you highlighted. So the 7 points which you highlighted, seeing that whether the field is reliable or not, and till looking at the congruency, each point if we apply, it becomes very easy and each one of us can do it. I think there are some questions over there for fields. We can take that.
I think
somebody just asked when to repeat the fields after neurosurgery. So I think maybe it is around 6 weeks. I would like to repeat in majority of patients.
So with, I think let's go on and
continue with the next speaker. So our next speaker is Dr. Digvijay, who will tell us about the pearls and pitfalls of OCT in neuro-ophthalmology.
Thank you, Dr. Savita. All right, so we've learned about visual fields, which is probably the most important investigation, for a neuro-ophthalmologist, for us to see neuro-ophthalmology conditions. And the optical coherence tomography, or the OCT, is not too far behind now. It's something that is gaining more importance, with every day passing. We're having publications coming out and a lot of things. So I'm going to quickly talk about the roles of an OCT. So we all know that there are, the OCT is basically kind of like an optical ultrasound, if I was to put an analogy. It's not exactly, but something similar. So it gives us an in-depth structural view of what is happening, while the fields were giving us a functional view. So the role of the OCT is quite significant in neuro-ophthalmology, and over the last 15 years, ever since the OCT has been around, and we've been having, more and more knowledge with regard to OCT changes in different neuro-ophthalmology, and not just neuro-ophthalmology, even neurology conditions. It has its role, it has its advantages in diagnosis, in probably planning and following up a treatment or a therapy, and the prognosis portion of it as well. So as far as the various scans that you could use in neuro-ophthalmology, you could use the disc tube, which is a standard scan where the optic nerve is looked at. It's something that we expect to use. It could be in the form of a 3D disc. The most recent OCTs, the spectral domain OCTs, or you could have a time domain, which gives you a 2D view, or a view in different angles, and you could use that to compare. The other scans are the raster scan. As you can see here, we've used it to look at a disc pit. You can see a fluid coming all the way up to the fovea along with that. And you could use the RNFL. This is probably the most important or the most commonly used scan in neuro-ophthalmology conditions. And then you have the ganglion cell layer, or the GCL scan, which is there. Again, something which has been gaining popularity of late. This is taken on the macular tube scan. So in terms of the the diagnostic role, it's essentially a supplemental field. So the supplemental use, the OCT on its own alone will never be the one having the or making the diagnosis for you. So you have to always do a clinical correlation. And you could look at it to look at whether there's a papilledema or a pseudopapilledema, and we'll come to these examples where there's papillitis or neuroretinitis, or you could have it in the therapeutic or the prognostic use. The OCT is, when I say therapeutic, the OCT is not something which is giving therapy, but you could follow up a treatment. Again, in cases of, let's say, IIH that you're looking at, you could follow up a treatment, or in a pituitary adenoma, it helps you to give a prognosis of what will happen after neurosurgery. Or in LHON, you can see whether it's in the acute phase, are you still in the period where you want to intervene. And the uses in neurology are essentially for multiple sclerosis and, particularly optic neuritis. Of course, we are expecting there to be changes, but even in multiple sclerosis without optic neuritis, there is RNFL thinning, there is ganglion cell layer loss. In Alzheimer's disease and Parkinson's disease, we have found that there is loss in ganglion cell layer in the retinal nerve fiber layer. And in fact, this is a good biomarker for, being able to evaluate whether there's going to be progression in these disease or in the disease severity. Of course, in pituitary adenomas, like I said, you can get it's like a prognostic marker. And these are some publications that Professor Rohit Saxena and we did together at AIIMS on the OCT, and there are plenty more, but I just taken out 3 which were corresponding to the diseases here. And we found that yes, that the OCT does play a significant role. So now let's quickly look at the pearls of the OCT. The first and foremost, probably the most important reason of using an OCT would be to differentiate papilledema from pseudopapilledema. So here I want to introduce the concept of something known as the Kupffer-Smith's angle, which is the angle between the RP and the basement membrane here, Brooks membrane, and it's pointing inwards towards the vitreous cavity. While normally, whether it's an edema from NAION like this or an edema from an optic neuritis, it is going to be pointing outwards towards the optic canal. So if you look at this inverted U-shaped swelling of the disc, then you know that this is something which is a papilledema. And this does not actually correlate with the RNFL findings, but it does tell us that that this is possibly a true edema. Again, it's not 100% sensitivity specificity, but just another marker or a pointer in that direction. So let's look at a few cases of a swollen disc. So the first case here is a 32-year-old female, who is having obese, was diagnosed as a case of IIH, suspected as a case of idiopathic intracranial hypertension. So I'm not going into too many clinical details, just focusing on the OCT. And you can see here on the RNFL scan that there is a lot of edema in the retinal nerve fiber layer, and all the values are way beyond the normative data values. And when it comes to such large swellings of the optic nerve, the automated software actually fails, so it doesn't give you very accurate values. You can in fact look at the total retinal thickness if you want as well in such cases. But this clearly tells us that there is an edema, and you can look at the here you can look at the line scan which have been extracted, and this shows you the positive angle, Kupffer-Smith's angle. Here's another 30-year-old female who had a sudden loss of vision in one eye, was diagnosed to be papillitis. You can see here that there is a subtle edema in the right eye, but here if you see that you're not seeing that positive angle, it's in fact the regular RP Brooks membrane pointing outwards from the eye. An elderly female here who had a vision loss on awakening in the morning. You can see the right eye vision was about 6/60. If you look at the fundus images, you can see that there was a disc edema here. The left eye seemed okay. And when we did the OCT, we could see that we did catch hold of the swelling on the RNFL map. Here I just expanded that. And in fact, here also when we did the macular tube, even up to the GCL. So there was involvement beyond just the peripapillary area. And the visual fields showed a constriction in that eye, not typically what we would expect in a NAION, but this was a case of an NAION. And over time, the patient was given systemic control, and the vision improved. But now that we're on the topic of NAION, lately in the OCT angiography, they have found changes in NAION, which are there in the acute phase. You can see here, in this case, that there is a dropout in the peripapillary capillary area. Here, of course, because of the edema, a lot of this is hidden, these red arrows, and this is taken directly from the publication. I don't have an OCT angiography at my disposal as of now. And this is corresponding to an inferior field defect. The other eye, fellow eye, is quite normal. You can see the normal retinal vasculature and the normal peripapillary capillaries, and the choriocapillaries are also normal as well. So this is an image from the deeper choriocapillary layer, and this is an image from the more superficial peripapillary layer. And about 8 weeks down the line, you can see that there is a dropout in the peripapillary capillaries. You can see these black areas that are coming up here. The field affected persists, but the choriocapillaries were more or less not affected. So they've said, or they found that the larger retinal vessels sometimes become less prominent. And initially in the acute phase, you could have dilated peripapillary capillaries or the capillary network, which later on would get attenuated. And in chronic cases, you'll find it to be attenuated. So this is a newer finding. I just thought we'd mention it here. If you look at another case here of a female who's about 56-year-old with some vision loss in the right eye, and the optic disc looks swollen, and this has been looking swollen for a very long time in this eye. In fact, even if you looked at the previous records, many times she was being treated as different things. But when we looked at the fields, you could see that there was a constriction there. On the ultrasound, there was a hyper-reflective spot here. On the fundus here, what you could see was a slight nasal, supero-nasal buried drusen. So this is something that the OCT could pick up. Not exactly the classic, it is buried, but it's not exactly the classic look though. And you could see that there was some RNFL thinning corresponding to that area. So as drusens would start becoming superficial from being deeply buried, you could have thinning in the RNFL and visual fields defects, which could vary from just a large blind spot to a full constriction, or any field which would look very much glaucomatous in a. If you look at the, this is the enhanced depth OCT now. And if you look here, the drusens are a lot more clearly seen. So the ED OCT is what is probably going to be the investigation of choice for drusens. And you could in fact use any spectral domain OCT like that if you go a little closer to the cornea and have an inverted image. But if you have that ED module, enhanced depth module, that's the ideal situation. But again, not all of us would have that at our disposal. Now let's look at some other optic neuropathies or optic atrophies, and how do we differentiate them from glaucoma. So remember, in glaucoma, there would be more involvement of the superior and the inferior discs. There would be a larger cup. In neuro-ophthalmic conditions, the temporal and the nasal quadrants would tend to get more affected. In glaucoma, the nasal is rather resistant. And these are, of course, soft pointers, and the cupping is usually not so much. If there's gross asymmetry and pallor, of course, in clinical, and you're getting this kind of a red image, as you can see in the upper OCT here, then you know that this is probably a neuro-ophthalmic condition. But as I said, thinning of the RNFL is not specific for any neuro-ophthalmic condition. It just simply means that there is a loss in the nerve fiber layer, and that could be because of glaucoma or other reasons. So here, if we look at a 22-year-old male who had a vision loss in both eyes, was on ATT, showed a central or a centrocecal defect, temporal pallor. And when you look at the OCT, you can see that there is a temporal thinning in this case here, and this is the quadrant is more affected. And even on the macula, you can see that while in this OCT machine, we didn't have a separate GCL IPL layer, but you can see that there is a thinning that is coming about. So even the GCL layer would have been, or the ganglion cell layer would have been thin in this case if we had that module with us on this machine. Here's another interesting case of an 8-year-old male who presented with gradual vision loss in both the eyes. And when we looked at the images, you could see that there was disc pallor in both the eyes. And in fact, his younger brother also had vision loss. So this was diagnosed clinically as a case of autosomal dominant optic atrophy. And we did the OCT here predominantly from a point of view of following up as to how quickly was he losing the nerve fiber layer. And you can see that there is no color coding here because this is below the age where the normative data is available in the OCT. Normally 18 years and above is where we have the normative data. So you get a blank white chart, but you do get the absolute values of the RNFL. And you can see that the double hump is kind of obtunded. You can't see a very nice double hump sign here on the NRR or the RNFL, as well as you can see that there is the overall values are lower. And this was the younger siblings OCT that we did. And you could see that both of them are showing some thinning. And this was something we could follow up over time to see how they're doing. Now let's look at the pitfalls. What care you need to take when you're looking at the OCT. The first and foremost is that you always need to do a clinical correlation. So here is a young male who presented with what looked like somewhat pale discs, but the OCT was showing thinning. You thought that this could be some kind of an optic neuropathy. The fields were normal, but you need to see that the clinical correlation was that this was a myopic patient, and it was a high myopia, and therefore the optic nerves were actually physiologically showing a little pallor. And when we did an HRT, you can see good tick marks all around. So that means that the optic nerve was actually within the healthy range. In these myopic cases, the HRT sometimes works better than the OCT itself. If you look at this here, you have to make sure that the scan is centered. This patient, when we did an OCT, you could get this big peak here, in the NRR and RNFL you can see, but the reason is if you look at the left eye is that the scan was decentered. Look at this, if you can see the arrow. And when we repeated the scan, we got a completely normal report. So you have to make sure that the scan has been taken properly. Don't just interpret it as edema, wrongly. Similarly, remember the RNFL can never be zero. If you're getting a zero RNFL somewhere, then think that there's something wrong with the scan which has not been acquired well. And here you can see a shadowing, and that is why the RNFL here is appearing to be zero. So redo the scan and you'll get a normal value. This is the scan of that same young child, the one I talked about who had the autosomal dominant optic atrophy. You can see that we're getting such haphazard line going up and down, and this is definitely an indication that the scan is not well taken. And if we repeated it, this was a movement artifact, you could see that the scan now gave a very nice graph. So these are just a few of the pitfalls that are likely. You have to be careful. And pseudoedema is something. So if you get a hypermetropic disc, sometimes it may appear to be edematous there, or it's a young patient. You may get RNFL which is slightly beyond the normal values. That should not be mistaken with edema. And in some scans, you can see there is slight myelination of nerve fibers or a thick RNFL. You can see that the scan wrongly picks it up. See this marking that it has taken beyond the disc margins, and that is why you're getting what looks like potential edema. So make sure that you have an option of manually marking the disc if the discs are looking slightly different. So you need to look at all these things, when you interpret an OCT. So the take-home message is that yes, it is an important tool for neuro-ophthalmology. It's an important supplemental tool. We always do a clinical correlation. The GCL and the RNFL are most important. In fact, on this, an important point that comes out is that if you can do both scans. Sometimes in cases like Leber's hereditary optic neuropathy or early edemas or papillitis, you may first get thickness of the RNFL to be high, so you wouldn't know if there's been any loss. And the GCL layer is what will truly give you what is happening in the acute phase of the disease, because the GCL IPL will show you a thinning even when the RNFL is showing you thickening. And that indicates that there is an edema in the disc area, which is why the RNFL is wrongly giving you a thick value or a green value, while the GCL IPL, which is truly giving you the red value, showing that there is a loss of axons that is happening. So both these scans are important scans to do. And of course, make sure that the scan acquired is good, because your interpretation is going to be as good as the scan that you acquire. Thank you.
Excellent presentation, Dr. Digvijay. There's just a question for you. How do you ensure a good scan? Because your key take-home message was that do a good scan. So what are one or two key things you would talk about a good scan?
So I think, whenever I do the scan or I ask my technician to do the scan, I always ask them to do three things in that. The first is that you must correct for the refractive error. So you must optimize in the machine. So there is an optimize option in most machines, or you can manually also enter it in the older machines, so that the machine knows that this is potentially a myopic disc or a hypermetropic disc, and it gets you a focused scan. Second is look at the signal strength. The signal strength should be good. You want the closer to 10, the better, but at least you want a signal strength of more than 7 or 8 if you want a good interpretation. And lastly, make sure that the disc has been correctly chosen. In slight edemas or slightly tilted discs, or in situations where there's a myelinated nerve fiber, the automated software is unable to pick up the disc boundary. So I always tell them to correct it manually, and all machines have that option as of now. If you do that, then you know that you've correctly taken the disc. Of course, I think that said, still the absolute values in papilledema and all are sometimes not accurate in the machines. So despite you making a correction, you can't rely very well on those values.
So a wonderful presentation, Dr. Digvijay. And I think we've essentially covered everything there is to the OCT. OCT is still a tool which we are understanding, and the RNFL and the GC-IPL are increasingly being used to understand more prognosis and follow-up, particularly when we're looking at optic neuritis, we're looking at papilledema. So Dr. Kapper-Smith's presentation in one of the INOS was this exactly, which Digvijay pointed out, that there may be in the early stages increase in RNFL thickness, but the GC-IPL may actually start showing a thinning, which is reflective of damage and chronicity and long-standing pressure-induced damage happening to the visual pathway. So that's one of the key things we are learning. The GC-IPL will be very helpful. And as neurologists have increasingly been using this for neurological diseases and their reflection in the retina, we hope that the OCT starts giving us interesting diagnostic as well as prognosticating information. Dr. Virender.
Excellent presentation, Dr. Digvijay. I agree completely with what Dr. Rohit pointed out. And I would like to add one more point is that as we are looking at the artifacts or like pointers, signal strength of more than 8 is important. Also to try to look at some black areas, which suggest possibly there was a blink artifact and the machine did not capture. So that could also help. Also, sometimes a tilted disc will cause a erroneous value. So do look morphologically for it. And as regards GC-IPL, one more advantage of this is that the changes in the GC-IPL could actually correlate with the visual fields very well. So if you have a bitemporal hemianopia, you would see that there is a thinning on the nasal side. And in NAIMN, you might be able to see that there is a segmental loss of the GC-IPL and there is a corresponding inferior altitudinal field effect. That kind of thing also goes a long way. And possibly the biggest role of OCT as compared to HUF is in monitoring. So if we are establishing a baseline, then we are able to follow it, whether the change is happening. And over there, again, GC-IPL scores over RNFL because changes occur faster in the GC-IPL as compared to RNFL. These are small other additional points.
So one question.
I have a quick comment to make if we have time.
Yeah, sure.
So yeah, so just as what was emphasized previously, so the GCC combination of GCL with RNFL is very important because sometimes, for example, subtle things that we can't pick up, a skull-based tumor, for example, a very small anterior clinoid meningioma will give vision loss from compressing the optic nerve. But if we do the RNFL, and sometimes it could be misleading because the RNFL could be completely normal. And if you look at the fundus, the optic nerve could look normal too, despite the significant decreased visual acuity and coloration and the visual fields. And sometimes we don't even see a disc pallor on the fundus examination as what we expect to see. But if you look at GCL, there could be significant thinning of GCL. And this is because the compression is causing axonal sluggish, so that can mask the presence of a disc pallor. And so that's one of those conditions that the GCL can provide really valuable information. And another example would be somebody who had a IIH but also had a VP shunt. So the shunt is actually controlled the papilledema, so patient recovered, but then patient come back with increasing headache. And so if you look at the optic nerve, we may not see much, especially if the patient has already developed optic disc atrophy in the past. So a very small increase in the intracranial pressure and a small increase in the papilledema may not show up readily to our eye when we examine the fundus. So in that case, the RNFL scan would offer a significant value because the RNFL scan will see a increase of the RNFL in the order of less than 10 micrometers, which will be important information suggesting that might be a problem with the shunting. So there might be a shunting malformation. So so these are the two examples where the OCT can specifically important in helping us with the diagnosis.
Thank you, Dr. Chen. So to summarize, we need to have RNFL and GCIC in all our neurological suspect cases. So our next speaker will be Dr. Chen, who will be discussing with us the MRI of visual pathway.
So hello, everyone. So today I'm going to talk about the application of the MRI in localizing lesions on visual pathway. So I'd like to thank the previous speakers, especially Dr. Somali. She's already had a very good introduction of the visual fields. So that makes my job a lot easier. And so today we're going to start it out with the basics of the MRI, and then this will be followed by case presentation. So when evaluating visual pathway, MRI is usually the preferred imaging modality. MRI captures the radio frequency signal emitted by the proton atom in hydrogen nuclei. And MRI provides a high resolution imaging of the anatomy and the physiology of the human body. And it does not involve ionizing radiation, which is a huge advantage over X-ray based testing. So MRI utilizes a large number of sequences and the protocols. And with new modalities rapidly emerging, we don't need to remember all of them because it's hard to catch up. And the MRI sequences that we come across the most in ophthalmology practice is T1 weighted, T2 weighted and FLIR, and T1 with a contrast study. So MRI abnormality of the visual pathways is usually demonstrated as T2 hyperintensity and contrast enhancement. T2 hyperintensity can be seen in inflammation such as optic neuritis, central nervous system demyelinating, or acute hemorrhage. Contrast enhancement lesions usually indicate active acute optic neuritis or active MS demyelination, infections, or brain tumor. So now, when we read the MRI, we first have to be able to tell the T1 weighted from T2 weighted because these are the two main MRI sequences. So there are very sophisticated ways to differentiate T1 from T2. And here I just want to introduce a brief way, a quick way, simplified way to differentiating between the two. So if we look at the T1, remember that T1 is the best sequence to delineate the anatomy. So therefore, in T1, the white matter here looks whitish and the gray matter looks gray. So if you see this kind of contrast, we know that we're looking at T1. And the T2 is the opposite. So in T2, the white matter over here looks grayish and the gray matter looks whitish. And also in T2, the CSF signal looks bright. And so that's how we can tell that this is T2. However, in especially processed T2 weighted FLIR, the CSF signal will be suppressed. So that means the ventricle will look black, just like a T1. But however, the gray matter and the white matter contrast will remain the same. So that's how we tell T2 FLIR from the T1 weighted image. So a problem with orbital scan is that orbital fat is always hyperintense, meaning that it looks bright in both the T1 and T2 over here. So that this bright signal can obscure the visualization of the orbit. So because of that, a special protocol is developed called the fat suppression. So in fat suppression, the orbital fat is the signal of the orbital fat is taken out. So then we can see the optic nerves and the extraocular muscles a lot better. So now we're going to go over some cases. So case 1, 15-year-old girl with vision loss in both eyes over 1 week, and the visual acuity was down to no light perception in both eyes. So on the fundus photo here, we see optic disc edema in both eyes. So with this fundus photo, we know that the lesion, although it's bilateral, the lesion is probably close to the optic nerve. So now we have the MRI of the orbit with fat suppression. So this is a contrast study. So the lesion here is actually standing out so much, it's screaming at us. So what we see here is the edematous optic nerves and intense contrast enhancement over the entire intraorbital segment of the optic nerve in both eyes. So this is consistent with optic neuritis. So the patient was treated with steroids with a full recovery of vision to 20/50 in both eyes. So here is another case, a 31-year-old lady with MS who noticed a decreased vision in the right eye for a few days with a slight dull ache in frontal area. So visual acuity was down to 21/60 in the right eye. So here we have a Goldman visual field. On the left eye looks completely normal, and the right eye looks like there's an inferior attitudinal effect. So this visual field vision loss, acute vision loss associated with eye pain in a young lady with history of multiple sclerosis. So this is highly suspicious for retrobulbar optic neuritis. So now we have the MRI here, MRI of the orbit with effect suppression, T1 contrast, and axial on the left and coronal to the right. So let's look at the axial first. So by looking at the axial, there's really not much standing out immediately, not like the case, the last case. So then we have to look at the coronal more closely. So it looks like this coronal is cut through the optic canal because we don't see the extraocular muscle anymore. And also we see this guy, this little guy over here. So a shape of a triangle with a dark signal surrounding the iso-intense bone marrow signal. So this is anterior clinoid. So immediate to anterior clinoid, we find the optic nerve. And so now we can compare between the two. And so now we can see the differences. So left optic nerve looks completely normal, right optic nerve looks enhanced. So this is a consistent with right optic optic neuritis. So let's go back to the axial with this information over here. Now we can say maybe, yeah, there does look like there's an enhancement of the right optic nerve just within the optic canal. So the take-home message here is that when the inflammation of the optic nerve is very localized, especially if it's localized to the optic canal, then a lot of times it may not show up very well in the axial scan because it's very subtle. And sometimes even radiologists will overlook that finding. And then, so in that case, we know that it is in the optic nerve. We have to look at the coronal really closely. And on the other hand, a general rule of thumb. So if we see a lesion, we better see it in more than one sequence. If we only see it in one sequence, then we have to question whether that's artifact. So the optic chasm can be readily recognized in coronal image. So here we have coronal T1 without contrast on the left side, and then with contrast on the right side. So optic chasm looks like a T here. And this little stick over here, that's the pituitary stalk. And then this is squared hyperintense structure, that's the sella turcica, which houses the pituitary gland. So we have a case here, looks like there's no question, this is bitemporal hemianopia with visual acuity of 20/20 and 20/20. So this localizes to the optic chasm. So now we have the MRI of coronal, looks like this is T1 without contrast. So here we don't see that classic T structure anymore. Instead, we see this thin little band riding on a big mass underneath. So this is the optic chasm, but it's compressed. So it's compressed and stressed very thin. And so this tumor here looks like it's growing out of sella turcica. So this most likely, this is pituitary adenoma. So this is a typical bitemporal hemianopia. And this pattern of visual fields is already introduced by Dr. Sonali. So this is what we call junctional scotoma. So this patient presented with vision loss, quote unquote, in the right eye. And however, the visual fields also shows a visual field defect superior temporal in the left eye. So in the right eye, it looks like the whole entire optic nerve is involved in the left eye. So if we see this superior temporal defect, it's respecting vertical meridian. So there are two possibilities. The one is this superior temporal defect in the left eye could be a component of left homonymous hemianopia, or it could be a component of bitemporal hemianopia. So either way, we need an MRI. So this is the MRI coronal with contrast study. So now we look at this picture over here. It's actually quite similar to the case on the right. So we see this thin band, that's the stretched out optic chasm. And then beneath that, we see a large contrast enhancement lesion growing from sella turcica. So this is another pituitary tumor. But despite the similar look of the MRI between these two cases, the visual fields looks very different. So that's because this tumor here is compressing not only the optic chiasm, but it's also compressing the prechiasmatic optic nerve on the right side, so causing junctional scotoma. So optic nerve involvement in the right eye and plus a bitemporal hemianopia. So next, 11-year-old boy with new onset headache. So the visual fields over here shows left homonymous hemianopia. But look at the pattern. This is the visual field defects between the two eyes. They don't overlap. They don't look exactly the same. So this is incongruous left homonymous hemianopia. So this lesion looks like this could be most likely in the right optic tract. So the next question will be, how do we find an optic tract? So optic tract is different from the optic nerve and optic chiasm. So optic nerve and optic chiasm are standing out in the MRI as distinct white matter tracts, but optic tract does not, because it mingles into the parenchyma, so into the mesiotemporal lobe, and it's wrapping around the midbrain cerebral peduncle over here. So those are the anatomical landmark that we use to find the optic tract. So now this over here, we see this is T2 flyer. So we see a T2 hyperintensity abnormality in a easily defined area in the right mesiotemporal lobe. So this is where exactly the right optic tract is traveling through. So this lesion extended up to extended into the superior, into the right thalamus. So looks like this could be a low-grade glioma. So 37-year-old Caucasian male with mental fog and headache. So on the visual fields over here, looks like there's a left superior quadrant tenopia. And remember that quadrant tenopia can be seen in either optic radiation lesion, or it could be from occipital lobe. But usually occipital lobe lesion is more congruous. So looking at this visual field defects between the two eyes, it looks incongruous. So we see this is probably more likely to be from optic radiation. So optic radiation is divided into two parts. The superior fibers travel through the parietal lobe, and the inferior fibers travel through the temporal lobe. It's also called Meyer's loop. So interruption of the superior fibers in temporal lobe, in parietal lobe will cause inferior quadrant tenopia, and interruption of the inferior fibers in the temporal lobe cause superior quadrant tenopia. So this is probably from the right inferior optic radiation involvement in the temporal lobe. So now we have an MRI. So on the left is the MRI T2 flyer, and on the right is the T1 contrast. So what we see here is T2, a large T2 hyperintensity lesion in the right temporal lobe. And this lesion shows a mild contrast enhancement. So this turns out to be a oligodendroglioma. So visual fields associated with occipital lobe lesions is usually congruous, meaning that the left and right eye looks exactly the same. And also it could be unique pattern, and as either macular sparring over here, and or it could be a macular evolving. So it could be either superior, inferior, or both. Are we okay? Okay. So next case is 73-year-old male who noticed a dark spot missing near his central vision, as if seen after image from a wilding fire and the sunlight. Looking at the visual fields over here, so it looks pretty nice left inferior, a paracentral homonymous paracentral scotoma. So look how congruous. So the visual field defects between the two eyes look almost exactly the same. So this pattern has to be from the occipital lobe, and because it's central involvement, we suspected that this is in the posterior pole of the occipital lobe, right occipital lobe. So now we have the MRI DWI diffusion weighted image on the left, and ADC apparent diffusion coefficient on the right. So what we see here is what we call the diffusion restriction in the right occipital lobe with a corresponding OCT ADC signal change. So this confirms the diagnosis of a right occipital stroke. and see how this lesion is affecting only the very posterior half of the right occipital lobe. So this corresponds to that paracentral scotoma. And the last case, a 73-year-old Caucasian female woke up with the worst headache in her life and altered mental status change. So on the visual fields over here showing right homonymous hemianopia, but see with a macular involvement. So we can probably figure that this is the opposite to the last case. So if this is macular sparing, then the posterior pole of the occipital lobe should be spared, and this should be anterior occipital lobe involvement. So this again is the DWI and the ADC. We see a large area of diffusion restriction in the left occipital lobe with corresponding ADC signal. So this pair is suggesting a left occipital infarct. But pay attention to see how this lesion nicely spares the tip of the left occipital lobe. So this is a nice demonstration of a correlation between the visual field defects and the anatomy. So take-home message conclusion, the pattern of the visual field defects correlates with the MRI findings, and this can provide valuable information to help to localize lesions in the visual pathway. Thank you very much for listening, and I'd be happy to take questions.
Thank you. That was a wonderful presentation and very nicely showed us the correlation between the field effects and the lesion that can be localized. So key things that we take from this is that, again, localization is extremely important. And by that, we can take a call on what to image. So the last two cases showed us that despite their being so early in their presentation, because of their classical presentation on their field effect, we were able to localize the lesion and do the appropriate test, because a routine MRI probably may not have picked up any findings in these patients. So we needed the ADC maps and the early changes to see for the infarct or the changes that are happening at that region. So there was a question that said that, why do you need to do anything? You can just do an MRI. So frankly, to tell you that now MRI is not just an MRI. There are so many things added to an MRI, just like the ADC maps we saw, that it has to be directed, and many things like fractures, infarcts, early infarcts, bony discontinuity, these things will easily get missed in a screening MRI. And MRI is also observer dependent, just like an ultrasound. If the person who's doing the MRI is not knowing what to look for, he may actually miss it. So if you're looking at multiple sclerosis and you're not doing fat suppression, so you may not enhance that mildly enhancing optic nerve all that much, or you may not see the dorsal fingers and the periventricular inflammation. So an excellent presentation, Dr. Virender.
Yes, Dr. Rohit, I fully agree. It was beautiful, full of all the correlation and something that everybody would be able to, correlate into their day-to-day practice. Dr. Chen, would you like to highlight what sequence you try to order in a patient with optic neuritis in your practice, as well as in a patient with a suspected cellular neoplasm? How do you build a differential diagnosis? Is there an approach you can give to the audience?
So for the optic neuritis, so in the States, so for the basic package of MRI, so that means that's the sequences included in the MRI wherever you go. Doesn't matter which facility you do the MRI. So will be DWI and ADC. So those are the pair for evaluation for stroke, and also T1 and the T2. So those are the basic package. So for us ophthalmologists, when we do the MRI, we like to have a T2 flyer. So that's the sequence, just like a T2, but it's a special T2 where we don't see the CSF signal. So that will make the subcortical white matters standing out nicely. And also in the special case for optic neuritis, what we need to order is the MRI of the orbit with fat suppression. with contrast. So number one, we need a contrast, and number two, we need effect suppression. So not all the MRI facility knows about familiar with effect suppression. So if you don't mention it in your order, a lot of times they don't do it. If you don't have effect suppression, that MRI is basically useless, and you just waste your money because we're not going to be able to see the enhancement of the optic nerve. So in terms of the imaging of the cellular turcica, meaning that we probably have a patient who come in with visual fields suspicious for, it looks like a bitemporal hemianopia, and then we wanted to do the pituitary protocol. And so now, but if you just order the MRI of the brain with contrast, and then, but in the comments you need to specify. We suspect there's a cellular tumor, pituitary tumor, for example. So does that answer your question, Dr. Veranda?
Yes, Dr. Chen.
And also, I couldn't agree more on Dr. Rohit's notion that when we order MRI, we can't just say, well, we need MRI, because radiologists, they are also very specialized. They need to have a differential themselves too. So they also need to have a clinical radiographic correlation. So a lot of times almost all the times, especially neuroradiologists, they actually started out reading the clinical note. So they need to know what is the differential diagnosis formulated by ophthalmologists. Then they can look specifically. Otherwise, there could be, because we're so specialized, sometimes the lesion is so subtle. And then at times, if they don't know what to look for, they could overlook that lesion. And then it's not uncommon actually in the radiology practice. So that's why, for example, if you suspect this patient had optic neuritis, you need to specify we're looking for optic neuritis. And also, because we have very nice information, for example, visual fields, that can help us to localize precisely what exactly we're looking for. So just put those information in the note, and then so radiologists would appreciate that information for them to make a correct diagnosis. So that's what I want to emphasize.
So the next presentation is by me. I'd be discussing about VEP, visual evoked potential. So visual evoked potential, or VEP, is definitely an important tool in an armamentarium. It's basically the only objective technique available to assess clinically the functional state of the visual system beyond the retinal ganglion cells. It's record of gross electrical signal generated at the visual cortex in response to visual stimulation. Basically, it extracts the waveforms from the EEG by signal averaging. However, the precise origin of the stimulus is not unclear, but definitely VEP will reveal the afferent visual pathway lesion. So any damage downgrade, it will cause a disturbance in the signal. Primarily, it is a function of the central visual field, because the occipital cortex gives a maximum area or has a magnified foveal projection at the cortex. So sometimes the peripheral visual loss can be overlooked by VEP also. Now, just about what are the prerequisites. The machine which we use here is a Roland consult machine, and we need those electrodes, a monitor, the Gansfield bowl to give us the flash stimuli, monitor to give us the pattern stimulus, and the reading screen. So the patient has to be absolutely in a relaxed position with refractive correction. It can be done both in undilated as well as dilated states. Monocular recording is possible, and there should be no distracting sound or light waves. A flash VEP must be done in all patients when pattern VEP is not feasible. Coming on to electrodes, the electrodes position is based on the 10-20 system, where the distance between the enion and the nasion is calculated. Enion being the most prominent part of the occipital cortex, and suppose it's 40 centimeters, 10% of that, which is 3 to 4 centimeters just above the occipital cortex, the active electrode is placed as seen in the figure. The ground electrode is over the forehead, and the reference electrode is placed, the ground electrode is on the vertex, and the reference electrode is on the forehead. So based on the type of the stimulus, there are three types, either a flash pattern or a pattern onset offset. A flash is the response which is elicited from a diffusely flashing light which obtains a visual angle of visual field of 20 degrees. This is merely a crude response. It just tells us whether the integrity of the visual pathway is there or not, whether the impulses are received by the cortex, mostly done in cases of uncooperative children or aphasic children. And the other thing which we commonly use is pattern stimulus. Pattern, as the name indicates, it's pattern reversal, where alternate black and white stimuli are used, and so they reverse. So the one cycle is like 2 reversals per second. The illuminance and the background remains constant when this gets changed. Pattern reversal is more appropriate because it is like it remains same throughout the normal population. The standard deviation is low. It gives a closer relation to the form sense and the visual acuity, and this is the most commonly used VEP in our practice. Pattern onset offset is something which is less insensitive to like moving stimulus, which is less sensitive to nystagmus. It is used in malingering as well as in nystagmus cases, but it has a lot of inter-subject variability. So in pattern on and off, as we see here, a equiluminant diffuse background and a black and white checkerboard pattern is alternated. It's also used in malingering because they cannot defocus so rapidly to a fast moving stimulus. Interpretation, just remember the NPN complex, where the NPN is the first negative wave that comes at after 75 milliseconds, the next positive wave at 100 milliseconds, and the next negative wave at 135 or 145 milliseconds. So P100, these are the typical waveform which is usually given in adults of 18 to 60 years. We do not have normal values for children, and P100 is the most consistent and least variable peak. Amplitude and latency are what the parameters what we need to see. Amplitude is something which is measured in microvolts, but it has inter and intra-subject variability, whereas latency is measured in time or milliseconds. Latency is defined as the onset of stimulus to the peak component, not just the onset of the P100 wave, but the P100 peak. It is more reliable. So P100 is 110 milliseconds in patients younger than 60 years, thereby it increases to 125, 130. But though some normal values are given, it is recommended that every lab sets up its own normal values and then correlates for pathology. So these are the three waveforms which comes out from flash VEP, pattern reversal VEP, and pattern onset offset. In flash VEP, P2 is the most reproducible wave which we need to look at. In pattern reversal VEP, P100 is what we have to see. And in pattern onset offset VEP, there are three waveforms like C1, C2, C3, which comes at say 90 milliseconds, 110 milliseconds, but this keeps on changing, and therefore this is not recommended in general practice. So majority of the P100 response arises from the central 8 to 10 degrees of the visual field. This has, as we discussed earlier, an amplitude reduction of more than 50% or a latency delay of more than 15 milliseconds is highly suggestive of some change. So this is a short slide about pediatric VEP as per the International Standard Classification of Clinical Electrophysiology of Vision. So they recommend that monocular testing to at least one stimulus is desirable. Binocular pattern stimulation, which facilitates attention and fixation, can be done. The analysis time for children should be 300 milliseconds or longer. Usually in adults, it is between 200 to 250 milliseconds. And children with good vision, the peak time of the main positive peak of pattern reversal for larger checks is usually within 10% of adult values by 6 months of age. So infant of 5 weeks of age, VEP can be done, a flash VEP, and the peak comes around closer to 200 milliseconds. And this matures over time to by 4 to 5 years, the peak time shortens to about 100 milliseconds. Sweep VEP is another modification of VEP where it has been recognized as a valuable technique for measuring visual acuity and contrast sensitivity. As the word indicates, sweep, that means a sweep of the stimulus is a faster stimulus within a lesser time frame it can be obtained. So it gives us a rapid and objective estimate. So for it can check both visual acuity and contrast sensitivity with a continuous sweep of linear light and dark responses. From low to high, the spatial frequency is changed, and to the highest spatial frequency to which the visual system responds, the visual acuity is recorded. For contrast, the spatial frequency is kept constant, and then the lowest contrast to which the response is elicited, that gives us the contrast. Basically, they average out the responses from 4 to 5 stimulus, and then the visual acuity is correlated. It relates to Snellen's visual acuity in terms of cycles per second. So by birth, or they say early after birth, it is 4 to 5 cycles per second, which gradually increases. So with this overview, we discuss few of these cases. So this was a 10-month-old male who had where parents complained of poor eye contact, had nystagmus, stack visual acuity was 20,000 at 38 centimeters, and the child had diffuse dyspallor. Clinically, we would say that there's a poor prognosis based on diffuse dyspallor. Basically, this was referred from neurosurgeon to get a VEP done. It was congenital aqueductal stenosis, and the child had undergone a surgery too. So as we see, what we have done here is a flash VEP, and the flash VEP in these cases shows that P2 is prolonged beyond 110, and even the amplitudes are less. So basically, it is just a tool to assess vision. But however, not only VEP, in cases where we have to differentiate, like in milder cases or in cases of LCA, or ERG is also important. This is another case scenario where a 5-year-old girl had actually neurofibromatosis and bilateral optic nerve gliomas. So initially the vision was not affected, optic nerve was not involved, and the waveforms are reproducible. P100 and amplitude is normal. Over 3 years later, we see that the P100 is increased to 135 and 132 in both the eyes. And after 4 years, the waveforms are not at all recordable. So this will give us a clue that we can monitor the progression and sometimes avoid MRI unnecessarily, that how much it is affecting the vision and how it has progressed. Another case scenario where a 28-year-old female presented to us with left eye decreased vision since 1 week, associated with headache, no pain on ocular movements. Right eye vision was 20/20, left eye 20/200. Left eye she had grade 2 RAPD and color vision 4/17. This is a fundus picture of the left eye, possibly normal or little hyperemic. And then we definitely advised her, as discussed, contrast enhanced MRI with T2 and flares. But also a VEP was requested, and where we find that the VEP in the right eye is P100 is 105 milliseconds, whereas in the left eye it is 145 milliseconds. So there's a 40 milliseconds interocular difference. Anything greater than 10 milliseconds interocular difference signifies that there's some abnormality in conduction. So this was classical of optic neuritis, and the patient underwent treatment with IVMP. So furthermore, we can see that increased latency of P100 is also noted in subclinical or chronic cases. In another case scenario, in 50-year-old male who presented to us with decreased vision in the right eye since 10 days, right eye visual acuity was 660 and left eye was 6/9. Right eye grade 2 RAPD, color vision affected, 9 out of 17 plates. And these are the fundus pictures where we see classically in the right eye, the size and the shape cannot be commented upon. The disc margins are blurred, the cup is obscured, the vessels are not traceable. There's a splinter hemorrhage inferiorly, very classical of NAIN types. And when fields were done, this is an inferior altitudinal field defect in the right eye. Left eye was normal. Clinically, we do not need a VEP in these cases because based on the history, the age profile, one can make a diagnosis. But this paper by Janke et al., which they have studied, and the role of electrophysiological findings, they say that in the affected eye, there is decreased amplitude as well as prolonged latency in eyes with NAIN. Again, they have also reported in this paper that if there is a monocular affliction and the other eye is disc at risk, that eye also showed decreased amplitudes on VEP, on pattern VEP. This is a condition of 18-year-old male who came to us with right eye decreased vision since 2 months post RTA. Right eye visual acuity was 2400, left eye was 20/20, N36 color vision. He could not even read the demo plate, grade 3 RAPD, but temporal pallor has not yet set in. So at this point of time, we need a VEP to know what is the optic nerve status. So VEP here, a pattern VEP has been done at 2400 vision, which has shown that P100 is 122 milliseconds in the right eye. As we see, the waveforms are also blunted in compared to the left eye, and in the amplitude is also decreased 4.45 microvolt in compared to 25.5 of the left eye. So basically, in TRON cases, in cases where there's a bilateral TRON, even VEP finds its application. Cases where there is periocular edema or the patient is comatose or sedated, where pupil assessment becomes little difficult. In cases where there's a dense vitreous hemorrhage, and along with that, there can be traumatic optic neuropathy, which cannot be ruled out. A VEP will give us a clue if it's an acute case whether an IVMP can be given or not. This is another case of toxic neuropathy, which in a 25-year-old female who was on ATT since 6 months and complained of decreased vision in both the eyes since 3 months. Visual acuity was 636 right eye, 624 left eye. RAPD was not there and the color vision was affected. Fundus was normal. So in all these cases, we just evaluate with OCT, VEP, and HVF wherever possible. So this the HVF did show centrocecal for scotomas. I have not put here, and pattern VEP shows that the P100 is again prolonged to 126 and 123. So the more importantly, the role of pattern VEP in toxic neuropathy comes as a detection in subclinical ethambutol toxicity. So there are multiple papers who have studied that for subclinical detection ethambutol toxicity, VEP and OCT has been useful. In this, in another paper, where is a prospective study done by Saxena et al. They have proved that it is a suitable test in absence of any change in visual function. Like if the visual acuity has not yet been affected, color vision, RAPD are not there, fundus changes or field changes have not set in, pre-starting ethambutol and post at the baseline and after 1 month or 2 months of pattern VEP will show us that this prolonged P100. And at that point of time, discontinuation of ethambutol causes reversal of VEP changes. It has been reported that the change can be as early as 1 month or even as late as 12 months. So therefore, it is recommended that this can be used in routine monitoring of ocular function in patients treated with ethambutol. This is another case where a 56-year-old male presented to us with decreased vision since 3 months in both the eyes. Visual acuity was counting fingers, half meters. Pupils had brisk reaction, no RAPD, anterior segment was normal. This is the fundus pictures. As we see, the fundus also looks normal. And we definitely advised him with an MRI contrast. And meanwhile, we also got a VEP done. Fields were not possible due to profound vision loss. VEP again shows that there is prolongation of P100, signifying that there is some optic nerve dysfunction or the visual pathway dysfunction. And when we got an MRI done, we found that this patient had a craniopharyngioma, was urgently referred to the neurosurgeon. The other case scenario is albinism. In this case, they would have nystagmus. It is important to distinguish them from congenital nystagmus. So in albinism, what happens is they have a preponderance of misprojection of optic nerve fibers. Basically, the fibers which cross at the chiasma are 53 and 47%. But there is a temporal fibers decussation in this condition, causing an abnormal projection to the occipital cortex, leading to a VEP asymmetry. So there's a crossed VEP asymmetry in this case. But to detect this VEP, one active electrode is not sufficient. We have to have electrodes in the hemisphere where 2 other electrodes are placed lateral 3 to 4 mm away from the central electrode. So as we see in this waveform, so if it is left eye's response from the left electrode is a normal waveform, whereas there is a crossing over and this gives a reverse different waveforms of the left eye from the right hemisphere. Similarly, it is noted in the right eye also, so that there's a crossing over. Because of this crossing over, there's a contralateral representation of the waveform. So there is lateralization. But in achiasma, where there are less crossing of fibers, it gives symmetrical crossing over. As we see, so the right eye occipital electrodes will give this waveform, and the left eye occipital electrode will give the representation from the same side or the same hemisphere. The other uses are during orbital or neurosurgical procedures. It's a continuous record of optic nerve function in form of VEP to prevent inadvertent damage to the nerve. And degenerative diseases also show that there's a delay in pattern VEP. Multifocal VEP is a newer technology or a newer thing as a modification of pattern VEP, which actually documents the visual field as a collection of evoked cortical responses. So it records the signals from 60 different regions, as we see here, black and white 8 squares, and each 60 region is single stimulus, and then a software-based calculation is done, and the waveforms are such that they eliminate the noise window and the signal window. This is the normal waveform, how a multifocal VEP comes. So the importance of multifocal VEP is that it has ability to detect small abnormalities in visual signal transmission from centric as well as eccentric field, and it definitely provides a topographical display of these deficits. So just to summarize, VEP affecting one eye, it can be optic nerve involvement or amblyopia, affecting both the eyes. If the responses are symmetrical, it's a bilateral visual pathway dysfunction. In case it is asymmetrical and crossed asymmetry, can be a chiasmatic lesion, chiasmal tumors. And if it is uncrossed asymmetry, then it's a hemispherical lesions, or as we saw in albinism. Thank you.
Thank you, Dr. Suvita. It was an excellent, very comprehensive presentation covering all aspects of VEP. For the VEP, it is a little important to know that there are only specific questions it answers. So it's a particular test that is, you have to ask the right question to get the right answer. Otherwise, frequently you may get misled because there are changes that tend to overlap and are not often disease specific. So sometimes, particularly for prognosis, and Dr. Virender has written in chat very important aspects about optic neuritis, involvement of the other eye. So often we pick up color, contrast, field changes in the other eye of optic neuritis, which may manifest as subclinical involvement, and VEP is one such change that happens. And always you need to have a specific question in mind which the VEP will answer. So where there is a doubt as to the other thing Virender has pointed out is malingering. So where there is a doubt as to is the vision correlating with the extent of lesion or damage we are seeing, there you may be able to know in traumatic optic neuropathies with vitreous hemorrhage, with including the pupil involvement, where maybe pupil is not sensitive enough, or you're not able to get the pupillary responses, you will be able to know whether there is optic nerve involvement or not, and you should immediately give steroids or not, as Suvita has pointed out. So again, in children where they don't see, so parents come with questions like, does my child see? What is the vision in my child? So those are conditions where we can use these investigations to help us to add knowledge or information to us. But indiscriminately ordering the test, just like we are ordering MRI, like the problems of doing an MRI without application of mind. Similarly, we are a very specific test which should have very specific indications. Virender.
Yes, excellent talk, Savita. And as Dr. Rohit pointed out, I think it gives us a limited information that we should catch in the context of the setting. That if we keep in mind, it is very helpful investigation. But doing it in all cases may or may not add value to the workup of the patient. So where we are suspecting demyelination, it's very important, possibly in traumatic optic neuropathies and functional vision loss. These are the three most important indications I perceive. But less in monitoring, definitely we can do the monitoring like in a patient with compressive optic neuropathy, where we are not ordering repeat imaging, either with the follow-up OCT seeing the change, or with the follow-up VEP. There also it can be used.
I have a question for Dr. Savita. So can you comment on how you use VEP for monitoring for ethambutol toxicity? Specifically, how's that VEP change correlate with the clinical change of visual acuity color vision, for example, visual fields? And number two, how do you make a decision to discontinue ethambutol based on VEP change?
So basically, we have not done the pre and post part, but patients who come later, and if it is like an acute case, then we go ahead and do a VEP. But if it is like 6 months and we are knowing it is all neuro investigations are showing favoring, it's like a toxic neuropathy, then the subsequent VEPs we do not do.
Okay, I see. That would make sense. And also another question, what's the rationale to do VEP in other types of vision loss, for example, ischemic optic neuropathy or compressive or MS? Because when they presented, we have all the vision examination. We know that they have optic nerve dysfunction. And so how's that VEP is gonna add or provide additional information for us?
I agree with you. For ischemic and all, even we don't do routinely VEP. I just presented that was a study which they had found.
Okay,
I think very rightly pointed out, although the presentation covered the VEP changes in all available neuro-ophthalmic disorders, however, its indications are very specific. So
yes.
She's very comprehensively picked up on NAIO and the changes, and like traumatic optic neuropathy or for that matter in changes in compressive optic neuropathy. But there it does not really help us much as far as diagnosis is concerned particularly. So that's why again the reiteration that the VEP has very specific indications where it is useful, it is extremely useful and gives us a lot of information for diagnosis as well as prognosis.
Thank you. That makes sense.
So a question on use of VEP in monitoring for ethambutol toxicity. Virender?
I think I don't use it for monitoring for ethambutol toxicity. I would monitor the patient more with the visual fields and including the central 10-2 fields in case I have a greater suspicion, and do the complete visual function as you previously said, like look, high contrast visual acuity, low contrast visual acuity, color vision. They are very sensitive. But if we are having a suspicion, very strong suspicion, possibly we can add it to our armamentarium. Have you been using? I think you have some experience.
So, yeah, we had done the study and we did find that the VR changes probably precede most clinical tests, but I would still say that it does not probably give us enough information and enough robust information for us to change the ATT or to stop. So we would still say that clinical testing and among the earliest to change are color and contrast, and of course visual field effects. But color and contrast are fairly easy to do, and patients, if they are explained that these may be things that they should particularly notice, color desaturation, some contrast changes, they may help us to pick up toxicity much earlier rather than doing VPs, because there is no time when you can do them. So if a patient presents with a visual functional deficit, yes, a VP would very, very quickly and robustly tell us that there is toxic changes, even when we may not be so sure about the visual functional deficit. So it may help when patients present to us rather than as a screening tool. So I would say, as Virender says, clinical testing is still the most appropriate way of testing and picking up toxic optic neuropathy early.
One of the places I feel that VEP does a good job in terms of ethambutol toxicity is, in certain children, sometimes the pediatricians want to start. In India, particularly tuberculosis, we're getting a lot of resistant variety. So I normally get a baseline VEP done whenever they send me for a clearance that can we go ahead with ethambutol, because the child is unable to tell the color vision or contrast sometimes, or the visual fields is not very effective. Still, a VEP does give us a baseline VEP, and then you can repeat it. So what are your thoughts, Professor Saxena, on this?
So that's interesting in very small children, but again there we have the problem of the VEP not being well fixed for them. So a little bit of variability in them is still there. So yes, in children in whom visual testing may be a problem, VEP may help us, but again I would still say pupils and clinically it would be, but it's a very interesting idea, and I guess that would really be something which you could actually look forward to. There was a question on OCT in ethambutol toxicity. So OCT in ethambutol toxicity we have seen is a late presentation, so that again would not be useful for diagnosis, but we've seen that patients who have OCT changes over the long term had probably subclinical or involvement of the optic nerves because of the toxicity of the drug, which may not have been clinical. And there is one very interesting paper that had come some time back, which had tried to correlate the OCT at the time of visual dysfunction or presentation with the final visual acuity, and they found that there is some correlation. So if a patient presents with visual dysfunction, you get an OCT done, it may probably help us to prognosticate whether this patient will gain normal or good vision or may remain subnormal vision, which is an important question which we need to answer when these patients present to us.
So one of the pitfalls in the OCT and ethambutol is we have to be aware that sometimes, especially on somebody who is elderly or has diabetes, has a vascular disease in their body, their baseline OCT could just show significant thinning. especially in the macular scan GCC. So if we only have one scan showing diffuse thinning of the GCL on the elderly with all that background condition, and then sometimes we can't just make a decision saying that, yeah, it is truly related to the ethambutol. So for that kind of patients, we'll need a longitudinal kind of follow-up data.
Absolutely. I don't think OCT, again, is not one of the tools in which we would, stop ATT at the moment. So it's probably not. I was just saying that there was an interesting paper on prognosis, on the outcome of vision. So patients presenting with vision loss, the baseline OCT may help us to, prognosticate vision, but of course not, helping us diagnose ethambutol toxicity.
Completely. I have a question. So, Dr. Rohit, in your experience, how many months do you think the VP change is gonna precede the clinical change of vision?
In which condition?
No, the VP. I'm sorry, the VP. How long?
VP in ethambutol toxicity.
Yeah.
So I did not proceed significantly. I mean, it was the earliest pickup that we found. So when we were following up patients with on ethambutol to pick up for early, we found that VP changes were there in these patients, and some of them over the next follow-up, which was usually a month, presented with changes in their color and contrast, and some of them didn't even do that. So over time, we did find that after 6 months, we found some changes in their OCT, which actually told us that probably that BP increased latency that we were seeing was probably related to the ethambutol toxicity, although we did not stop treatment at that moment because of that slight increase in the latency. So again, we didn't do, more frequent follow-ups. Our patients were following up after 1 month. And even when we were doing VPs, the subsequent 1 month follow-up only for visual, subclinical visual deficit, and not none of them presented with clinical visual dysfunction.
Okay, interesting.
That's very interesting, Dr. Rohit.
And unfortunately, ATT has been changed in India, and we have ethambutol now going on for 6 months. 6 months. So we hope that we don't see an increase in ethambutol toxicity, and I think over time we should, as a group, get on and try and raise a red flag for the physicians, pediatricians, and internists about the importance of advising the patients to have a regular vision examination, or at least a self-check at home, so that we can pick up visual dysfunction early.
So how often do you monitor? Do you do follow-up examination in ethambutol monitoring?
So that's a very difficult question, because most of them don't want to come to an ophthalmologist, and we generally at the moment are recommending a first follow-up at 2 months, and then subsequently a 6-week follow-up up till the complete treatment of 6 months, and of course an SOS the moment they feel that there is a visual dysfunction.
Okay, so
we're doing only clinical examination at that time. So we're not repeating, because there's a lot of patients who are actually on ATT. So other than a clinical exam, at the moment, we're not doing any other investigation unless we suspect there is early toxicity.
Thank you. Looks like there are lots of new messages.
So Virender, a discussion on HRR versus ISHIARA. So what color vision testing would you prefer?
Yeah, so if it is available, possibly HRR is more sensitive. It helps detect the acquired color vision defects more easily and earlier. But if we don't have, ISHIARA is still available with us, and it does a decent job, especially if we try to avoid the first 9 plates. Afterwards, we pay more attention to them, we possibly can see these changes more often as well over there. So rather than just counting the number of plates, if we try to see which plates are getting deficient, that gives a little bit more information whether something is changing there or not.
So any other comments on color vision, Dr. Chen?
Oh, I'm sorry. Could you?
Any comments on color vision testing, routine or for investigational purposes?
So for color vision testing, we routinely use Ishihara plates. So that's what we use in the clinical office examination. So if there's any questions, so for example, patient comes in and complain of decreased color vision, but all the other clinical examinations are unremarkable, meaning that there's a discrepancy between the clinical testing. Then we usually pursue a Farnes wall Mansell, the 100 hue testing.
100 hue test.
Yeah. So to further assess the color vision, but isolated color vision deficiency, except the congenital color deficiency, I'd say it's very rare, and meaning that the only abnormality is the color vision abnormality, and all the other visual fields or OCTs or the visual acuities are all normal, and usually we have to suspect that this is either one of those congenital or this is something just unreliable testing or sometimes functional. And in this occasion, actually, I think VP and or advanced OCT testing will probably provide important information just to look for those subtleties that we miss maybe in the other type of visual examinations. That would be my take.
Great. We have some great comments also coming, Dr. Samira, Dr. Cynthia. So we have some, great neuro-ophthalmologists who are commenting on the chat, and it's always interesting to read their point of view. Dr. Suvita, anything you want to add?
Dr. Rohit, one quick question. Would you also, that would be the ideal scenario, what I feel. Would it be ideal to get a baseline eye exam also for patients being started on ethambutol? Though in our country, it will be too many consults for us, but maybe that would be ideal.
Not only work for us, which we always would welcome, but it is very difficult to convince. I mean, it's very difficult to, in fact, the resistance is more from physicians, yes. Which I found. So despite repeatedly requesting them, they don't even send patients over for an eye exam, even when the patient sometimes does talk about a visual dysfunction. So for them, it's the hepatitis and the systemic involvements of INH and rifampicin, which is key. And once they're over that initial 2-3 weeks of systemic disorder, they're really not very concerned, and that's most unfortunate, because that's the reason why we see a fair amount of ethambutol toxicity, and unfortunately, many of them come so late that it becomes irreversible. So again, it is awareness from our part as a group. Everybody to make the physicians, the internists, the DOT centers, we should try and mobilize and send posters there where they could put up that, we have a Snellen's chart there, mark a 6 meter and say that, just check your vision. If you can read as well as you were reading before you started your ATT, probably you're good. So every time you come on a monthly visit, you come and just check your eye exam, just get a visual acuity at least. So I guess now so many apps are available. Color vision is possible on your phone. So again, these are key things. I think as a group, we should increase our, the awareness among physicians and internists. And that's the only way. I don't think patients will come to us. It's extremely unlikely. So it's probably we should go to them, or at least, just like we are on online. So we should go to them on an e-platform and try and get their attention. But
yeah,
exactly right.
Exactly. Thank you.
Thank you, sir. I think we have really short time, and it was a wonderful discussion. I think all of us learned many points, more than what we are practicing. Some things we may not change. It is basically the neuro-ophthalmology evaluation is clinical evaluation, and all these diagnostics will just aid and help us choose between what is the next test and when to order, and how do we prognosticate, or how do we go ahead. But I think everybody has learned what are the various applications of these tests in our practice. I would thank everybody. I would thank Dr. Chen specifically, because she is right at now 7 a.m. or 7:30 a.m. with us. And I would thank Dr. Rohit, Dr. Virender. There was a quite interactive discussion. Not only it was like a audio, it was a verbal discussion, but there was a lot of discussion going on in the chat session also, which everybody would have learned. I would also like to thank Dr. Satyakarna. He was also replying. Dr. Shailaja. Everybody was quite active. And let me thank Dr. Suma once again for this opportunity. And my co-speakers, Dr. Digvijay and Dr. Sonali, all of them have presented excellent, and fellows and residents would have learned a lot. Thank you, everyone.
Thank you, Suma, and thank you, Suvita. It was a wonderful
the whole team.
Thank you, everyone.
Thank you for inviting me too. This is an interesting conference because I myself learned too, because the pathology is so different between the two countries that we practice at. So we learn the stuff that we don't normally see. For example, ethambutol. Yes. This could be very different pattern clinically. So thank you. It's very nice meeting you too.
Thank you. Our pleasure.
Thank you.
Okay. Bye-bye.
Thank you, everybody.